Okay, up next, Professor Marc de SMET, looking at natural course and complications to look out for in non-infectious posterior uveitis.
Well, thank you very much. Thank you, Vishali and the IOSG. I think you've had a very nice set of presentations that were given to you about the minimal imaging set and how to diagnose many of these flex syndromes that we see in the posterior pole. So I wanted to broaden it a little bit since we're talking to comprehensive ophthalmologists and maybe show you a slightly different way of looking at posterior uveitis. And just to start off, I think it's good to remember that there are about 40 to 50 different syndromes or presentations of uveitis. And probably the majority, how do I advance here? The majority of the cases you're going to see are anterior segment in about 80% of cases. And while most of those can be treated with just anterior segment drops, they can present with some posterior segment manifestations. In particular, if you're doing wide field, you'll be able to find some vasculitis in the periphery in a large number of individuals. But in practice, what you're really interested in is the amount of vitritis that is present or the development of cystoid macular edema. And if that's present, obviously you have to treat it accordingly. Now, if we group the posterior cases, you've heard about many of these white dot syndromes or flex syndromes that we've talked about, but there are also some other conditions that may affect the retina. And so I like to separate them into the ones that have vascular involvement, the ones where we see granulomas as being a hallmark, and the ones that have flex syndromes. And all of these can lead to cystoid macular edema, glaucoma, and in the case of vasculitic problems, they can lead obviously to atrophy. And if we have granulomas, and you've seen some of these cases already presented where they involve the RPE, the deeper retina, the ellipsoid zone, as these lesions persist and respond or disappear on their own, they will often lead to a zone of atrophy. And so with vascular involvements, you want to see where they are, which vessels are involved, if it's just the retina or the choroid, and you need to have some idea of where you are in the disease course. Has it just started, or are we looking at types of recurrences? And the inflammation itself may lead to either retinal hemorrhages, cotton wool spots, the presence of exudation. It may just involve the posterior pole. It may involve the microvasculature or larger vessels. And in all of these cases, you're also interested in looking at the optic nerve and the presence potentially of some edema that is developing the macular area. So multiple sclerosis is a common disease, at least in our part of the world. The macula often is not all that involved. We'll see peripheral lesions and also involvement of the optic nerve. This is very helpful in terms of diagnoses. The disease itself sometimes can be granulomatous in the anterior segment, and accordingly you want to treat the whole patient, that is systemically as well as the eye involvement, either topically or with local treatment. Now, this is something we've already talked a little bit before. I don't think you'll see much of it here. We see it in the Western countries, in Europe and America, mainly in white patients. This is birdshot. It has a very subtle type of appearance. And in fact, it is a vasculitis because it involves both the retina and the choroid. And that's why Vishali mentioned that in trying to make a diagnosis, it's important to look at the ICG as well as the fluorescein. ICG may show you some granulomas that are accumulating inside the choroidal area, but it will also show you both early leakage, and also you do not see the vascular detail in the later phases of the ICG when you have a very active disease. Patients often will complain of having some degree of nyctalopia and some degree of vision loss, although early on you see very little inflammation inside the eye. But it is active disease that requires active treatment, and the difficulty with this particular disease is that you don't really see that much clinically, and unless you treat, the patient may become blind in about 10 to 15 years, but with treatment they do rather well. Behçet's disease, I'm sure you're very well aware of. It is an acute inflammatory disease. It affects both veins and arteries, And the big problem is, in fact, recurrent disease that ultimately will lead to loss of function, particularly in the macular area. And here, wide field imaging can be particularly useful in terms of follow-up. We also have idiopathic retinal vasculitis, where we don't find any other cause, and it is often associated with lack of vasculature around the macula, which ultimately will lead to some loss in vision and macular edema. Here's another case of idiopathic vasculitis involving the periphery, giving you macular edema as well as the optic nerve. And I think this is a very useful image that gives you, at least when we're talking about any kind of disease in the posterior pole, we want to make sure that we've eliminated mimickers that can be, for example, retinitis pigmentosa, the fact that we may have some infections, and then we have some common and less common diseases that can affect the eye itself. Some are more associated with a venous involvement rather than a arterial involvement, and these are, for example, sarcoid, birdshot, parsplanitis, and Behçet's. Granulomatous diseases, again, one of the ones I'm sure that you see is VKH. Granulomatous, it tends to affect Asians much more than we would find them in Europe, very much present in North America also, third or fourth decade, and it has both extraocular and intraocular manifestations, and a prodromal, acute, as well as a chronic phase. And in the chronic phase, what we see is involvement more of the anterior segment, although we can see recurrences in the posterior pole. And here I think doing angiography is useful initially. You will see first serous detachments. You'll be able to see these starry sky inside the retinal circulation when you do a fluorescein, involvement of the optic nerve. But for both diagnosis and follow-up, the use of the OCT is particularly useful. In the acute phase, you'll be able to see the appearance of, inside the serous detachments, these sort of membranes that are present. It's a highly, it contains a lot of protein, and they tend to deposit. You see choroidal thickening, and if the patient is treated aggressively enough initially, the choroidal thickening will disappear, and that is a very good sign of good response to treatment. If, on the other hand, you see the patient late, the choroidal thickening will not disappear all that quickly. It may also persist for a long period of time. And in certain lesions, you'll see also what was described by Sapna is the presence of these involvements of the outer segment and the ellipsoid zone overlying the areas where we see the choroidal thickening itself. There is depigmentation in the periphery that starts fairly early. It progresses more centrally if it isn't being treated. Ultimately, the person has a sunset glow fundus, but it can be stopped. It's very well seen on a wide field imaging, so I get this on all patients that have, in fact, VKH, and is one of the early signs that, in fact, you're getting good response also is the lack of progression of this depigmentation. In the advanced stages, you can see what it looks like. We also see a lot of these white little spots that appear that correspond in sympathetic ophthalmia to Dalen-Fuchs nodules. And if you image through these, you'll essentially see in the active lesion, just as in PIC, an area of involvement inside the outer retina, while once it quietens down, it just gives a zone of atrophy. Late stages, we also see some neovascularization that can appear, and these are difficult cases to treat when we reach that stage. This is typical of sympathetic ophthalmia in the early stages, so it looks a little bit like PIC, but of course the history is that there was trauma, either surgical or from another cause, and it tends to give you a granulomatous response. If you can treat it very early, aggressively, just as for VKH, you can stop this process. If you end up having to treat them later, they don't do quite as well, and they develop neovascularization in the macula, very often not directly associated with the presence of these lesions, and you also get atrophy around the optic nerve, as you can see here. And multimodal imaging can be useful here. Again, you can see these in the early stages, similar to what we saw with VKH, high content of protein as well as membranes that develop. And you see these lesions that are active that involve the RPE, the outer retina, as well as the choroid. And in a more advanced stage, it will just give you a window defect. Sarcoidosis, of course, is a granulomatous disease that presents in many ways. Classically, you can assess the degree of involvement by doing a fluorescein. I think that still remains very useful. But what is also useful is to get autofluorescence. It can give you an idea of where some of these lesions are present. Look for macular edema, and you should be able to identify choroidal lesions, granulomas, by doing EDI, and their disappearance with treatment allows you to know whether your treatment is being efficacious. You can also see some hyperreflective dots that correspond to inflammation inside the retina and the choroid, although you have to be careful that you're not looking at, for example, this lesion, which is a small vessel. These are recognized by the presence of an area of shadowing behind them, as well as their size, which is bigger, beyond about 40 microns when looking into the OCT. Now, granulomas you can image. You can see them both with regular photography by doing ICG or by doing EDI. The ICG doesn't necessarily correspond to the resolution of the lesion itself. That is better seen ideally by doing an OCT, as you can see in the image on the right, but you can also monitor it fairly nicely if you can get a full color picture, not the false colors that you get, for example, with Optos or with some of the either Heidelberg and other systems. Now, you've heard a lot about our flex syndromes. We can get some very good imaging. As you've heard from Eudes, using autofluorescence is probably a good technique in order to be able to see what's going on. You can also see it on OCT by reconstruction, where you're able to see in a en face image the presence of all of these lesions. And what, of course, is great with Eudes is that it resolves over time, and you can help the patient understand what is going on by repeating the imaging at a future date. This patient here is a patient that doesn't quite meet the standards that we've discussed. We've talked about PIC, multifocal, and indeed, when she first presented, she had a lot of peripheral lesions. Yet later on, when she came a few years later, she started to develop these lesions along the vessel, and also what we're seeing here more centrally close to the macula that started to progress. And so, as Vishali said, both ICG and the fluorescein don't necessarily give us much information in terms of the area of activity. Autofluorescence was best, and also OCT, because it shows you the zone of involvement at level of the outer retina and the presence of macular edema in this case. And this patient, after some time, finally agreed to being treated with more aggressive approaches using biologics. So in conclusion, the eye responds with final common pathways in terms of, and this can be macular edema, glaucoma, scarring, as we've talked about, and the presence of atrophy. It's good to be able to recognize these key syndromes by key manifestations. So it's either the image itself, as we've been talking about with the flex syndromes, or otherwise trying to identify certain of the processes, that is vasculitis, the presence of granulomas, or changes in the retina. Knowing where the lesions are located and their evolution, and in particular with the OCTs, is recognizing the involvement inside the outer retina, whether there is in fact a haze that is present within the outer the ellipsoid zone, or the presence of atrophy. This can help with the diagnosis as well as being able to identify response. And I think if you see one active lesion, this patient requires treatment, and that's in fact the name of the game, is to be able to recognize those particular conditions. And multiple imaging can be useful. There's a minimum set, and if it doesn't seem to give you the necessary answer, you essentially have to do more imaging to get a better idea of whether it's active or whether you have an inactive situation. Thank you.